Swayam Prabha. Digital India. Educated India.
Hello, I'm Dr. Anju Kagal, and here I'm back again with another episode on Mycobacteria. So, my previous lectures I've spoken to you about cultivable Mycobacteria, and today we are going to concentrate on the non-cultivable Mycobacterium lepra. Non-cultivable means it does not grow in artificial media. So, let us look at Mycobacterium leprae, the organism which causes leprosy. This was discovered by Hansen in 1873. It is a chronic infectious disease, granulomatous in nature, which affects the peripheral nerves and the mucosa of the upper respiratory tract. The disease, as you all know, exists since a long time. In fact, in the Middle Ages, patients were ostracized, and there used to be many leper colonies where they were vanquished to. And this was done because the disease causes a lot of physical disfigurement. In fact, in the 19th century, leprosy was believed to be a hereditary ailment. In a country like India, and there are still almost more than 10,000 cases of leprosy being reported per year. And these patients are also stigmatized and ostracized by society. The states in India where it is commonly found, most commonly in Uttar Pradesh and Bihar, and then in Maharashtra, Chhattisgarh, Orissa and West Bengal. These are the states which lead in the number of detectable cases of leprosy. How is this disease transmitted? It's transmitted through nasal secretions. Entry is believed to be through the respiratory tract or through broken skin. The main reservoir of this disease is humans, and it is also believed that the 9-banded armadillo also harbors the bacillus without really suffering from the disease. The risk group in leprosy, right from children to older people and people living in endemic areas, in poor conditions, and especially if they are immunocompromised. Mycobacterium leprae has a special predilection for superficial skin, the ears, nasal mucosa and peripheral nerves. It is believed that this happens because that part of the body is cooler than the rest of the body. In later stages, eventually this bacillus multiplies and can affect the internal organs, which would involve the testes, the eyes, bones, lungs and liver. How is leprosy classified? The Ridley-Jopling classification has been used for years, and this has the mainstay of this diagnosis has been the histology. So, according to the Ridley-Jopling classification, patients of leprosy can be divided into two large groups, tuberculoid leprosy, which is at one spectrum. These patients have few bacilli and have a good cell mediated immunity. On the other end of the spectrum, we have lepromatous leprosy cases where there are many organisms and there is immunosuppression. Between these, you have the borderline tuberculoid, the borderline and the borderline lepromatous cases. Now, this classification, as I mentioned earlier, was basically done on the basis of histology and determining an individual's cell mediated immunity, and therefore required infrastructure. The WHO classification is a more field friendly classification, which means that it is possible to diagnose cases even in the remotest area, and this depends on counting the number of skin lesions, based on which the disease is divided into paucibacillary or multibacillary. In paucibacillary leprosy, a patient has 5 or less lesions, whereas in multibacillary lesions there are more than 5. Now, this method helps in determining the kind of treatment that a patient gets. To demonstrate this, let me discuss a few case studies with you. We'll start with the first case study. A 25-year-old male presented to the OPD with a non-healing ulcer under his right big toe, quite similar to the picture you see in this frame. Now, this ulcer developed following a minor injury which occurred 3 to 4 months back. The patient had been going to his local GP but did not get any respite and the ulcer was not healing. On further questioning, the patient reported that prior to developing the injury, he had had tingling numbness in his right hand and right foot. Over the months, he also found that very often his footwear would slip off and he could not feel the heat of hot objects. So often when drinking a hot cup of tea, he found that he had developed burns on his hand. So here you have a 25-year-old male patient who's given a past history of tingling numbness and loss of sensation in the right hand and foot, and a non-healing ulcer. On examination, the patient had hypopigmented patches on his legs, upper part of the arms and torso, and these patches were anesthetic. In addition, on the knee he had annular reddish plaques with satellite lesions. His posterior tibial nerve as well as ulnar nerve were thickened and he had the beginnings of a claw hand. The clinician suspected that the patient had borderline tuberculoid leprosy, and since he had more than 5 lesions, he was labeled as multibacillary. Since the patient had come to a medical college and facilities were available, a slit-skin smear was taken from the outer edge of the eyebrow and from one of the hypopigmented patches. Now, how is this slit skin smear taken? So, you usually pinch the skin so as to reduce the bleeding, after which, of course, you have cleaned the site with spirit before you proceed, and then with a sharp scalpel you make a nick in the skin and you have to go little deeper and scrape the inside of the skin. Now this, whatever material is taken out, is then spread on a slide, allowed to air dry, and then sent to the laboratory. The smear, in this patient's case, smears were prepared and they were stained with Zn modified Zn stain. The modification here is that instead of using 20% sulfuric acid, we use 5% sulfuric acid because Mycobacterium leprae is less acid fast than Mycobacterium tuberculosis. A biopsy was also taken from the hypopigmented patch and it revealed a well-formed granuloma with epithelioid cells and lymphocytes. No acid-fast bacilli were visible. All these findings confirm that the patient was suffering from borderline tuberculoid leprosy. Appropriate multi-drug therapy consisting of rifampicin and clofazimine once a month under supervision, as well as dapsone 100 mg daily and clofazimine 50 mg daily unsupervised, was given for a period of 12 months. The patient was cautioned to be careful about touching hot objects and to wear covered footwear so as not to cause any further injury on his feet. Now we come to another case study. Sahil, a 50-year-old beggar, presented with bilateral tingling numbness both in his hands and feet, a glove and stocking kind of tingling numbness. When he presented, he had typical leonine facies as is seen in the right side picture of this frame. This leonine facies is a typical feature of lepromatous leprosy. In addition, he had loss of eyebrows, as you can see in the left side picture, and there was thickening of the ear lobes and facial skin. Slit smears collected from the ear and eyebrows showed many AFP, and a biopsy from the earlobe did not show any granuloma, but plenty of foamy macrophages filled with cigar-shaped bundles of acid-fast bacilli. The stain used for the biopsy was a white Ferraco stain, and a typical picture of this is seen in the photograph in this slide. Diagnosis of lepromatous leprosy was started and multi-drug treatment for multibacillary leprosy was given to the patient for a period of 12 months, after which he responded. This is a picture of how a patient appears after treatment. So let's look at the laboratory diagnosis of leprosy. So smears, like I told you, slit skin smears are made, or you can collect nasal secretions or a nasal scraping, or you can again take a slit skin from a hypopigmented lesion. Now earlier these smears were prepared from 6 different areas, which included the buttocks, the chin, the cheek, the forehead and ears, and multiple slides were made. Now this has been reduced to only the eyebrow and the lesion, and again multiple smears are prepared. Staining is done with modified ZN stain using, yes, you guessed right, 5% sulfuric acid. Again, you look for acid-fast bacilli in parallel bundles, and these cells are also referred to as Virchow cells or Lepra cells, and these can be seen in the photograph on this slide. So, the bacteriological index is calculated by adding up the score of all the smears and dividing by the number of smears seen. You can also do a morphological index. Here you do a percentage of uniformly stained bacilli out of the total number of bacteria in a tissue smear. This is useful in assessing prognosis and response to treatment. However, with the new WHO classification, these tests are not used unless you are faced with a patient who is not responding well to therapy. Okay, to complete the picture, laboratory diagnosis, we can also do a biopsy, and as I mentioned earlier, we do the Phyt Farraco stain, which is also a kind of acid fast stain in which we will look for foamy histiocytes containing acid fast bacilli. Cultivation of these bacteria in artificial media is not possible, but the animals in which it can be grown are, first of all, the foot pad of the mouse. In the upper right hand picture, you can see the foot pad of a mouse which has been inoculated, and there is a granuloma formation. Then the second picture shows you a 9-banded armadillo, and you can also grow this in the slender loris. Mice and slender loris are available in India. The 9-banded armadillo is mainly found in South America, and it does not breed well in captivity. Monkeys and chimpanzees can also be used. Now, when you want to inoculate the foot pad of the mouse, we usually take tissue from a patient of lepromatous leprosy and grind it before inoculating it in the foot pad. The lepromatous granuloma appears after 6 months, and this inoculation is usually done to confirm a dubious diagnosis in cases where there is drug resistance and to evaluate antimicrobial activity of newer drugs. The Lepromin test. This is actually an intradermal delayed hypersensitivity reaction in which we use the Dharmendra antigen or the Mitsuda antigen, and it is usually done to classify the stage of leprosy. There are 2 types of reaction which a patient presents with. The first is the Fernandez reaction, which appears about 24 to 48 hours after injection. The patient will have erythema and induration of 10 to 30 millimeters diameter, and it may be followed by a Mitsuda reaction where there will be an erythematous nodular lesion 3 to 5 millimeters in size, which appears 3 to 5 weeks later. In tuberculoid leprosy, you get a positive delayed reaction, and in lepromatous leprosy, there is no reaction. This test is not a diagnostic test and is used mainly to classify leprosy, to determine the prognosis, to see if the patient is converting from lepromatous to tuberculoid, and it does not indicate prior contact. Serological tests have not been very helpful in the diagnosis of lepromatous, in the diagnosis of leprosy. There is an antibody test. This test demonstrates antibodies against the phenolic glycolipid 1. It's a latex agglutination test. High titers are seen in untreated lepromatous leprosy, whereas low titers are seen in tuberculoid leprosy. Titers decrease after treatment, and it may be used for the diagnosis of borderline cases and for follow-up of patients. However, as I mentioned, this test is not used routinely. So you'll be wondering how I'm talking about antibodies here. Leprosy, being an intracellular organism, mainly is controlled by cell-mediated immunity. However, in lepromatous leprosy, antibodies to this organism are seen in larger amounts than in tuberculoid leprosy, whereas cell-mediated immunity is lower in lepromatous leprosy and higher in tuberculoid leprosy. Now let's look at some of the complications or sequelae of lepromatous leprosy. Now these usually occur in patients who have not taken treatment. There can be necrosis of the bony cartilage and the bones of the nose, leading to saddle nose formation. When the posterior tibial and median nerves are involved and there is anesthesia in the limbs, trophic ulcers can develop in the anesthetic areas, and the patient can land up with infection, as you can see in the upper picture, and osteomyelitis sometimes, leading to loss of digits, as is seen in the lower picture. If there is involvement of the eye, usually the patient presents with photosensitivity. There will be reduced vision, and on examination you would see retinal scarring and uveitis. The patient can also get glaucoma, and this can also lead to blindness. If there is laryngitis, there will be hoarseness of voice. Testicular atrophy can lead to sterility, and in some patients they may also land up with a terminal amyloid disease. Ulnar nerve involvement can lead to claw hand formation. Now I move on to another aspect of leprosy, and these are the immune reactions seen in patients with leprosy. These are usually acute episodes which are an expression of immunological instability, and they are a major cause of tissue injury and morbidity. There are 4 types: the Lepra reaction, erythema nodosum leprosum, Lucio phenomenon, and sporotrichoid pattern. The Lepra reaction is also called the Jopling type 1 reaction and is seen in the first 6 months of therapy. These patients develop erythema and swelling with pain and tenderness, and they may show a shift from borderline to tuberculoid state, in which case we say it's an upgrading reaction. Uncommonly, there may be a shift from borderline to lepromatous, in which case we call it a downgrading reaction. This type of reaction can occur in pregnant women and untreated patients too. Erythema nodosum leprosum is seen in about 25 to 70% of lepromatous cases, very rarely in borderline lepromatous leprosy. And this is a result of antigen antibody complexes which occur after treatment. It's a type 3 hypersensitivity Arthur's type of vasculitis. There are crops of painful red nodules, especially on the extremities. Sometimes these can become necrotizing and often associated with severe constitutional symptoms. Treatment of leprosy from being only dapsone therapy has now changed to multi-drug therapy. In paucibacillary leprosy, we give a 6-month treatment, which is daily unsupervised 100 milligram dapsone and supervised monthly rifampicin 600 milligram once a month. In multibacillary leprosy, treatment is for 1 year. Here again, there is daily unsupervised administration of 100 milligram of dapsone and 50 milligram of clofazimine therapy, and monthly supervised administration of rifampin 600 milligram and clofazimine 300 milligram. This is monthly and supervised. So these are available in blister packs so that the patient does not forget to take his medication. At the end of 1 month, the patient comes back with the blister pack and he is given the tablet of rifampicin and clofazimine or rifampicin alone, and then given his blister pack to take back for unsupervised therapy. There is no prophylaxis or vaccine available. There are many vaccine candidates, as we call them. In 1928, BCG was used to prevent leprosy. In 1980, Indian Council In 1980, ICRC in Mumbai developed a vaccine. This was a cultivable leprosy derived Mycobacterium, but it did not take off. In 1998, there was a leprosy vaccine developed and approved by National Institute of Immunology. However, that vaccine is also not being used. And in 2006, 2 specific antigens, MLO405 and ML2335, which are useful for antibody detection and possible candidates for vaccine, are being studied. But so far we do not have any vaccine available. So to conclude, I thought it would be useful to show you this slide of the diagnosis of leprosy. So in the top columns, we look at the WHO classification of possibacillary and multibacillary leprosy. The bacteriological index in the case of possibacillary cases would be in polar tuberculoid, that is TT cases, 0. In case of borderline tuberculoid, it would be 0 to 1 plus. In borderline multibacillary, the bacteriological index would be 1 to 3 plus, and in borderline lepromatous, it would be 3 to 5 plus, and in the case of lepromatous leprosy or polar lepromatous, the bacteriological index could be 5 to 6 plus. The skin lesions will increase from possibacillary to multibacillary, as will the nerve involvement. Possibacillary or polar tuberculoid leprosy is usually stable, as is lepromatous leprosy. So both ends are quite stable, and the in between BT, BB and BL are unstable, and patient can slip from one to another. Of course, the bottom part of the slide shows you how we do the calculation for the number of bacilli present in a smear. So with this, I conclude my lecture on leprosy. Thank you.